presentation.
And that was us recording you, Dr. Rodgers.
So can you guys share my screen, see my screen?
Yes, absolutely we can. And if you want,
Okay,
yep,
great.
perfect. Excellent.
Great. Okay. Well, again, thanks, Dr. Gainey. Thank you, everyone, for being here and taking the time out of your busy schedules. I'm Dr. Brian Rodgers, and I'm grateful to Dr. Gainey and Total Hearing for the opportunity to speak to everyone. So I'm what's called a neurotologist, and there's a quiz at the end. So no, just kidding. But basically, that is an ENT that focuses on the ears. Um, so complex diseases of the ears. And today I'm going to talk about an important topic to my work, and that's cochlear implantation. And it's my goal to sort of answer one of the questions that may be on our minds about cochlear implants, kind of the intro question, which is, am I a cochlear implant candidate? So I want it to be informal. I want y'all to stop me. Anyone who wants to ask a question at any point is welcome. Um, just an informal talk to try to get us all on the same page about, a complex topic, which is who is an implant candidate and who may be an implant candidate and how we answer that question. Can everyone hear me and see okay?
Yep, thumbs up if you can, chickens. Good.
Okay.
Yep, all's good.
Very good. Okay. All right. So I did not get consent from Dr. King to share her photo, so I apologize about that. But this is a little intro slide. A little bit about me. I'm from East Texas, Farmersville to be specific, and I went to Texas A&M Commerce for college. And while I was there, I got interested in medicine, and I applied to medical school and ended up at Baylor College of Medicine. And that's in Houston. So I went from small East Texas to Houston and spent 4 years there. And as fate would have it, I somewhat randomly was assigned to ENT, and I saw a cochlear implant at the VA, and I got hooked. And so I applied to ENT, and I went to Kansas City for 5 years of ENT. I met my wife there, so I got credentialed in ENT and got a wife on the way through my training. And then we went to Detroit together for a couple of years. She put up with 2 cold winters while I did my neurotology fellowship. We came away from there with a dog, moved to Dallas in 2017, where I started at Dallas Ear. And, now we have a growing family, a son and a daughter, and we live in Lake Highlands. So that's a little bit about me. Dr. King, she's from Lubbock and went to Texas Tech for undergrad and for audiology. And is that correct?
Yes.
Okay, I thought I heard a correction there.
Wreck them.
Oh, okay. We had some college, some fans, some Texas Tech fans. And she was at Dallas Ear as an intern, and then she started working as an audiologist in 2008, I believe, long before I was here. And she is currently one of our audiologists who, focuses on rehab with hearing aids, bone conduction implants, and cochlear implants. She's the director of our cochlear implant program, and just a valued asset, just a joy to work with. Patients love her. I love her. And so very grateful that she's here to keep me in line today. So, Basically, I'm kind of going to talk to you guys today like I talked to a patient in the office who is seeing me for the first time. Honestly, I'm talking to you more like I'm talking to a patient who has no idea about cochlear implants and seeing for hearing loss for the first time. And they have a severe hearing loss, and I'm informing them that they may be a candidate for cochlear implantation. So, in order to do that, patients, I feel like it's important for them to understand a little bit of the history of the cochlear implant. It's important for them to think like a neurologist a little bit as far as what's going on with their ear. I like to talk to them about how their hearing loss impacts their life, and give them kind of the perspective of some of my other patients that have ultimately gone on to have cochlear implants, and then to the nitty gritty of hearing aid use and hearing scores, unaided scores, aided scores, and those sort of things that really help us to not only qualify someone for a cochlear implant, but also to kind of let them give us an idea amongst different candidates, kind of what to expect, and to make sure that we certainly are picking people who have something to gain from the cochlear implant. And at the end, I talk about some special populations that I may encounter in clinic, and people that have outside indications for cochlear implantation. So, just a little basic history. The cochlear implant was invented. There's a few people that get credit, but to keep it simple, I'm going to say it was invented by Dr. House at the House Ear Institute in the 1960s. It's the first medical implant or device to restore human sense. There was a lot of resistance to this initially, a lot of just philosophical pushback, that this would not work, and that this would hurt people's ears and brains and things like that. So essentially, you're electrically stimulating a nerve, and there was just a lot of unknown about it. So a lot of initial resistance, but slowly gained acceptance. And in the 80s, it gained FDA approval for adults, and in the 90s for children. And from there, it sort of skyrocketed, and became much more accepted. In the early days, it was something that was mainly offered to those who were profoundly deaf in both ears. Initially, people with any amount of residual hearing were not candidates, but as we've gained decades and decades of experience, the indications have expanded to those with some residual hearing that are wearing hearing aids, and have some residual hearing that just aren't benefiting from their hearing aids, and even to those with normal hearing on one ear. Implants have been approved for single-sided deafness. So those things are expanding. Got a picture here of like one of the first cochlear implants, single channel electrode, rigid electrode and ground wire with the large processor there, in contrast to a more current child playing on the playground as if there's no difference between him and his hearing counterparts in his bilateral implants that are just attached to his ears there. So lot of progress there, but just kind of a couple representative pictures from the early days to now. So, what I'm thinking about when it comes to cochlear implant candidates is, let's see if I don't know if this is blocking you guys from seeing, but hopefully that helped, is what's going on in the patient's ear. So someone with hearing loss, when it's a sensory neural loss, assuming they have a normal eardrum, a normal middle ear, normal hearing bones, when it's a sensory neural loss, that is due to hair cell degeneration. So the cochlea there is the part of the inner ear that converts sound waves into nerve impulses. And it does that by detecting disturbances in the fluid that bathes these very specialized cells called hair cells. The size and the stiffness of these cells vary along the cochlear length, and that sets up what's called a tonotopic map, which means basically, to put it simply, a different pitch sound is going to hit a different area of the length of the cochlea differently, and that's how our brain distinguishes that's how our ear codes pitch for our brain to distinguish high versus low pitch. And so after the cochlear sound wave is sensed by these hair cells, it sends an impulse along the cochlear nerve to the brain for processing. And with age and different pathologies that are not necessarily relevant to why you're getting your cochlear implant, but with time, hair cell degeneration increases. Initially, patients mainly have a problem with the volume when there's a small amount of hair cell loss, and amplification via a hearing aid helps this. And as the degeneration increases, the density of hair cell population decreases. The quality of the sound starts to degrade, and there's distortion. And hearing aids, audiologists can tell us this better than I can, but hearing aids can help with that as well, with different programming techniques. And with further severe losses of hearing loss, you get what I would call a loss of aidability. So basically, there's so much loss in different tones that the sound is sort of irredeemably distorted, and hearing aid becomes, like our patients will sometimes explain, it's just amplifying noise that they can't understand. And so that's when it's time, at least on the ear level, that's when the disease or the loss of the hair cells may indicate it's time to consider a cochlear implant. So there's not really a convenient test to administer to patients to quantify hair cell loss. So therefore, we look for signs and symptoms that patients tell us in the way they act and their family members tell us, as well as we test them with an audiogram to see that a hearing loss is progressing to more severe levels. So we're going to go over some of those signs and symptoms that patients may be struggling with their hearing aids. So they really, hearing aid users that are struggling, they really need a very select environment. So challenging environments that cause them difficulty hearing may indicate that they're cochlear implant candidates. Someone like that might only hear when there's no background noise. The low level ambient background noise in daily listening situations is enough to overwhelm potential cochlear implant candidates, even when they're in their hearing aids. They really prefer quiet environments, one-on-one conversations, very close to the person who is talking to them, where they can look at each other directly. They struggle with technology. TV viewing is very difficult for these patients. It's quite frequent that cochlear implant candidates don't realize that they have the volume very loud. Their family members do realize that. They say things like, I can hear them from outside the house, or, if in another room, and ultimately their family members are not comfortable with the implant candidate's preferred volume level. They sometimes can adapt to this or adapt around this by using closed captioning, but that in itself is a clue that there's, a hearing problem, even with hearing aids. Same goes for the telephone. It can be very difficult for them to talk on the phone. And, it gets to the point where they request that people text them or use email, things like that. So those are some clues that a patient is struggling with hearing aids. Essentially, as they struggle more and more, they may develop adaptations to mask their struggles from others. They start to rely on lip reading, and potentially they don't even know that they're doing this until that adaptation is taken away, such as a facial covering, which conceals cues that they've become accustomed to. And sadly, as this progresses, patients, they don't want to be perceived as old or being difficult or a bother or a struggle. So they grow weary of asking friends and family to repeat themselves, and they get depressed about this. They may withdraw from conversations within their social groups. This kind of looks like the family members sitting kind of in the corner, nodding and laughing when they're supposed to, but not participating. Uh, and sometimes they avoid the situation altogether and become reclusive. They cancel events or don't schedule events. I mean, this is not what we want. These people need access to sound, and it can have a disastrous effect on their well-being, their social networks. They can lose touch with friends and family, and in severe cases, develop anxiety, depression, and even cognitive decline. So, very real, things that happen on a psychosocial level that we want to avoid. And then the other thing is that as they sort of feel their connection to the hearing world and feel the sounds and speech slipping from their grasp, they're going to try to do everything they can to fix that, and they may increase their frequency of visits to their audiologists. They may increase the frequency of upgrades or purchasing new technologies. And so these are also sort of subtle cues. None of this means that you're a cochlear implant candidate without doubt, but these are clues that someone with hearing aids is struggling, and we might want to know more about them. So when that is the case, we have a couple different tests that we apply, so in sequence, so to speak, as they sort of meet criteria of the more generalized test. We apply more specific tests, but starting out with unaided audiology. There's this kind of overgeneralization that is maybe a sign that someone's a cochlear implant candidate. So on an unaided audiogram, it's called the 60-60 rule. So for any patient who's looking at their audiogram, this is something that is simple to understand. But the 60-60 rule is just the idea that your speech reception threshold is increasing, and it's greater than 60. So if you look at this patient audiogram, their speech reception threshold, or SRT, is 100 in both ears. So yes, it's greater than 60. And then the other 60 in the 60-60 rule is a word recognition score less than 60. So that is the score here. I tell patients that the speech reception threshold is, sort of the volume required to hear, and then the word recognition score is how well you understand. And so both of those things are trending in the wrong direction in someone who is a cochlear implant candidate. So this audiogram is a patient's audiogram from Dallas Ear that was referred in for hearing loss, and ultimately a cochlear implant evaluation was done, and they went on to have a cochlear implant, and they're doing quite well with that now. So for an audiogram like that, our audiologist or an outside audiologist may be concerned that this is a person who is a cochlear implant candidate, or if by chance that's not the case and this patient just comes to me and I'm the first person they're seeing, then that's when I will start to talk to them about the idea of a cochlear implant. There are more specific aided criteria. That means testing done in the best aided condition. So that may be in the hearing aids that you're wearing, or it may be in an upgraded set of hearing aids, or maybe even just a testing loaner aid, but basically something that's powered enough to get the most out of your hearing. That would be what we would call the best aided condition. And so Medicare has these criteria. So someone who's being tested in their hearing aids, who has a limited benefit in hearing aids with some experience, I think 3 months minimum, but we like to see them having a legitimate hearing aid trial. They have moderate to profound sensorineural hearing loss, and that's based on their pure tone testing. And so, for example, that would be like a speech reception threshold, the same sort of idea of a speech reception threshold greater than 60, in the 70 to 90 range. And so then we do aided sentence testing for Medicare criteria. And I believe the current criteria is less than 60%. Feel free to chime in, Dr. King, but I have here, this might be an old slide. It's less than 50% in the ear to be implanted and less than 60% in the contralateral ear. I think they've simplified that to just overall less than 60%.
Yes, that is correct.
Okay. So that's the Medicare criteria. And so a lot of insurance carriers use this, and they may have slightly different requirements. But that's kind of, we're familiar, Dr. King and our team of audiologists is familiar with those different carriers' requirements, and we can apply, specific tests when needed. But overall, at Dallas Ear, we are, concerned not only with is your carrier going to cover it, but are you a good candidate? So what we do, we think to ourselves, in general, are you going to do better than you're hearing now? Can we feel like you're reliably going to do better with a cochlear implant? Can we expect it to be better than what you're hearing now? So if you have a high score, then we think it's unlikely we can get that high of a score with a cochlear implant. If you have a low score, then it's it's reasonable to think that this is someone who's a candidate because, in our perspective, they're going to do better with a cochlear implant than they're doing currently. Obviously, the lower the score, the less the less risk, or the more likely we're going to make someone better with a cochlear implant. We use a word score, CNC score less than 50%. But we, supplement that with a battery of aided word testing, aided sentence testing, aided hearing and noise testing. And again, the goal is to obviously meet the the insurance carrier standards, but also to make sure someone is a good candidate in our eyes, and also to kind of establish a preoperative baseline so that we can assess your progress after implantation, and know when to change course when things are, not much improved from your preoperative evaluation. So, and then if someone is deemed to be a candidate based on aided testing, then there's even kind of more of a medical second phase of testing that we do at Dallas Ear. So that's things like checking your anatomy with an MRI, preoperative balance evaluation, medical surgical evaluation to make sure that, this person who is a good cochlear implant candidate is a good surgical candidate. And so I can go into that in excruciating detail if anyone has any specific questions, but it's just the point being, it's just one other step towards evaluating candidacy for cochlear implant patients. And so in general, the most common person that is the candidate for a cochlear implant, um, we have to kind of decide which ear. We have to think about it, and it's a little bit of a nuanced decision to decide which ear should we implant, because in theory, both ears are candidates for cochlear implant, and that's been always sort of been the case historically. But more recently, we are, as I mentioned before, we are expanding into implanting people with asymmetric hearing loss. What that means is that maybe one of their ears is not really a candidate for cochlear implantation, and the other ear is clearly a candidate. So there's a big difference in the hearing in those ears. So we're expanding to implanting those patients. Um, when you have a patient like that, I think the insurance carriers, like to see that the ear to be implanted is quite poor, especially for something like single-sided deafness or asymmetric hearing loss. They want a CNC word score of less than 5%. So, basically the idea there is that the threshold for allowing coverage for an implant in someone who has very good hearing on the other side, that threshold is much harder to reach. And I think that made sense physiologically as well, because the greater the difference in the good ear versus the ear to be implanted, the higher the risk that the patient doesn't really get any benefit from the implant. And that's the last thing we want, is to put an implant in someone who ultimately feels as though it doesn't budge, it doesn't nudge the needle, so to speak, as far as making them a better listener or having a better hearing ability, because they still rely on their near normal ear. And some of these patients suffer from tinnitus, and while oftentimes we use a hearing aid to mask tinnitus, some of these patients don't get any benefit at all from hearing aid because of the profound nature of their loss. And so cochlear implant, a special population that may benefit from implantation, is that population that has tinnitus that doesn't respond to a hearing aid. And that's particularly true in our single-sided deafness population. So, I just kind of want to summarize by saying that the question, am I a cochlear implant candidate, does not always have a yes and no answer where we can just look at it and tell. It's a spectrum. It's something that, we probably, and Dr. King, please chime in, but we probably evaluate something like 5 to 10 people who are asking that question. Am I a cochlear implant candidate? We probably evaluate 5 to 10 people for every one or two people that actually are cochlear implant candidates, and we pride ourselves on that, and that's by design, that we're not implanting people that can benefit from hearing aids, to put it frankly, because if they do, that's always the preferred way to go there. So yeah, at the end of the day, I think I'm really proud of the cochlear implant program here. The team of audiologists that I work with are just a blessing to work with every day. We have great support from therapists, and I'm excited to extend those benefits to anyone in the audience today who would like to learn more about cochlear implants. So I'd love to answer any questions, and hopefully this has been helpful for everyone.
Dr. Rodgers, can you hear me?
Yes.
Yes. So my question is, what does the operation entail? Is that done through the ear canal, or do you open a wider area and kind of, give us maybe some highlights on how long the operation lasts, and, just trying to more academic rather than, I
Sure.
suffer this condition, but
You
I'd be
bet.
interested to know. Yeah, thank you.
George, thanks for the question. So yeah, the operation is it's a general anesthetic, and it is probably about an hour and a half, 2 hour operation, and it's day surgery. So you after surgery, you go to the recovery room for an hour or so, and after you pass a few clinical tests, you go home that afternoon. It's done through an incision behind your ear. Okay. So we pick an ear to be implanted based on your MRI findings, your balance test findings, but mostly based on which ear has the least hearing left in general. So we implant the ear that is worse off in general. And so, yeah, we make an incision behind the ear. We open up an area behind the ear called the mastoid. It's a pretty kind of a workhouse operation to open the mastoid to do a lot of different ear surgeries. It's the same for cochlear implant. The implant is essentially slipped underneath the skin of the scalp, kind of back behind the ear. And then the business end, so to speak, or the electrode of the implant is fed slowly into your cochlea, and it kind of wraps around the coil of the cochlea to kind of cover that whole tonotopic map that I was talking about earlier. Are y'all still seeing my screen?
Yes.
Yeah. So basically, the implant is fed through the mastoid and into the cochlea, where it kind of curls around and gives coverage along this whole map. So, and then as far as that goes, we close it up with absorbable sutures. You go home the same day. We ask people to take a week off of work, although most people tell me that was overkill and they can get back, they feel up to going back to work in 2 or 3 days. We ask people to avoid heavy lifting, more than 20 or 30 pounds for a couple of weeks. Then we see them back in the office at 2 weeks. And we try to conveniently couple that to the activation appointment with Dr. King or one of our audiology teams. And then that's when, for the surgeon, hopefully the journey sort of ends and it's on to helping, evaluate and maybe implant the next person, although we're still obviously a part of the team if there's anything that comes up. But what I tell patients is that's where the hard work of the surgeon is over and the hard work of the patient and the audiologist and the auditory verbal therapist begin. And again, I'm happy if Dr. King wants to chime in, but what I tell patients is really there's some variability in performance between different patients, and some of that is out of the patient's control. But what is in the patient's control? I say, sort of 3 things. Number 1 is the amount of time that you wear the implant. So there's a lot of data that shows that there's a passive neuroplasticity ongoing, and the more you're wearing the implant, the more you're taking advantage of that. And basically, we want you to get up in the morning and put it on before you brush your teeth, and go to bed at night and take it off after you brush your teeth. So it needs to be on the whole, as much as possible. The second thing patients can do that's in their control is they can keep their follow-ups with audiology. And, the audiologist is going to be the person who is updating the map, the program on the cochlear implant, making adjustments to optimize use. So they're fine-tuning the device to squeeze every ounce of juice out of it, so to speak. And so keeping those appointments is important. And then the final thing is the auditory verbal therapist. And a lot of times this is 1 or 2 sessions, and you can do a lot of it on your own at home. But the way I think of it is, everything I've described so far is more or less passive, but intentional listening practice with the device. Doing these auditory verbal therapy exercises, for example, taking 30 minutes to listen to a audiobook streamed into your cochlear implant. Just taking that time out of your day to really listen and work on recognizing speech and things like that. That's the third thing that you can do. So that's kind of the beyond the candidacy. That's kind of what I like to highlight about the experience of having a cochlear implant. So
Dr.
hopefully that's
Rodgers,
helpful.
it looks like there's a permanent implant, right? And then there is an external device that looks like a hearing aid. Are you talking about keeping the cochlear implant is, I would imagine, permanent inside the ear? And then the patient who has received the cochlear implant puts almost like a hearing aid, I would say. It looks like on the second graphic there that you have under the candidate there. It shows like there's a wire that goes behind the ear and then inside the ear. Am I right visualizing that, or?
I think this picture here is this is a candidate. So this is a person who has a hearing aid.
Oh, I see. I'm sorry. Okay.
But no, but that's okay though. Your question is a good one.
The picture of the boy, you could go back to the picture of the child. He had the cochlear implant.
Oh, so you have to wear all of that contraption when you have a cochlear implant, right?
Correct.
Oh, I see. Oh, okay. So it's very visible. I mean, socially, I guess it's very visible, right?
Yeah. I mean, I think that these pictures are good because they're showing you the cochlear implant. This patient has no hair. This kid has short hair with kind of a flesh tone device against his blonde hair, but it can be fairly subtle. But at the end of the day, to answer your question, the implant is under the skin. So you don't see the implant. This is the processor, right? So what I'm saying is I might have said you need to wear the implant all the time. That's a technical slip up. You need to wear the processor all the time. So wearing this processor is what makes the implant go. Without wearing this, sound has no access to the implant and you can't hear. So when I say activating the implant, that's 2 weeks of healing. And then you come to see Dr. King, and then we put this on for the first time with some, initial activation settings programmed into it. And, this is the link to the outside world for the implant. So this is how Dr. King programs it, and wearing it is how you use the implant.
But this is removable at night or removable at times? Okay.
Yes, it's just hanging by gravity on his ear, and it has a magnetic coil that corresponds to a magnetic coil within the device.
Oh, okay. So it's almost by
So this is the implant.
Yeah.
Are you seeing my
Mhm.
cursor? This is the implant, and then this is the processor on the outside, and it's connecting there via magnetic connection.
Do you
Dr. Rodgers,
anticipate,
if you scroll down.
Yeah. Do you anticipate that in the future, as you showed the first device, that this will be further miniaturized and become smaller, or where do you see the advances going with this kind of device?
Yeah, I think that there's a couple areas that are always advancing. The devices become smaller. The programs that Dr. King is applying to the devices, they study the algorithms and change those things. A current advancement right now is different size electrodes for different patients, and sort of programming custom programming to the position that the electrode lays inside the cochlea. But as far as it becoming more miniaturized, I mean, I do think that there is, I mean, frankly, there is an experimental, totally implantable device that, you know, there's probably been 10 implanted or something like that in Europe. But to qualify for that, you have to have a very healthy set of anatomy. This device is going to be the workhorse, for the foreseeable future.
Dr. Rodgers, if you scroll down a little bit, I think it shows one of the off the ear. Scroll on your left side of the screen.
Like a Canzo
So
or
that
something?
by cochlear, where it says cochlear nucleus, so that shows the nucleus 8, which sits on the ear. And then it shows the Canso 2, which is off the ear. So that's just sitting on the side of the head at the magnet site. Nothing's actually on the ear. So continuing to get smaller, continuing to make changes.
Right. George, what she's saying is with someone who's got this implant underneath their skin, they could wear the classic behind the ear processor, but they have the option of a smaller off the ear processor that's more subtle. This lady's wearing it.
Does the off the ear processor make things better for the patient or not?
No,
No.
it's
Dr.
all
King?
about preference.
Oh,
Some patients say, I'm ready to get something off my ear. I've had something on my ear my whole life. And then some patients say, I've had something on my ear my whole life. I want to keep it on my ear. So
Yeah.
it's really just about preference.
All right, those are some great questions. Do we have any more questions? You can type them out or you can shout them out. All right, we've got a question from John. For patients whose hearing loss is due to Meniere's disease, are they a good candidate for a cochlear implant? Great question. Dr. Rodgers?
Yeah, that is a great question. They can have a patient who has hearing loss due to Meniere's disease can have the full spectrum of hearing aid rehabilitation. In other words, if they have enough hearing loss to undergo a cochlear implant, then they can have a cochlear implant. I would say that Meniere's disease is often a unilateral disease, so we run into a little bit of a hurdle there. And so if you have a patient, for example, with normal hearing in one ear and Meniere's disease in the other ear, as we discussed, that can be a little bit of a hurdle, but not an absolute contraindication to a cochlear implant. So we assess their cochlear implant candidacy as a function of their hearing loss, the same as we would with anyone else. And it's not a contraindication to have Meniere's disease.
All right, awesome. Any other questions?
I will say one other thing about Meniere's disease is in a lot of cases, there's a phenomenon with regard to vertigo, the other problematic symptom of Meniere's disease besides hearing loss. There's a phenomenon called burnout, and it's usually later in the disease. So by the time a patient's kind of Meniere's disease kind of burns out and they don't have vertigo, they often have no hearing in the ear, and they're at that point, they're an ideal candidate for a cochlear implant. But occasionally we'll have a patient who continues to have vertigo despite having no hearing in the ear. And I've seen, I address that one of two ways. One is if it's really severe vertigo, then we can do a Meniere's disease surgery and a cochlear implant simultaneously. But often it is, if it's not really severe vertigo, we'll just simply do a cochlear implant. And I've seen some kind of a fringe benefit, I would call it. So you get better hearing from the implant. But the implant kind of nudges the ear a little bit further towards burnout, and they don't have the vertigo improves with the implant in some cases as well.
Wow, that's definitely a benefit. Yeah. All right. Any other questions before I announce the winner of the gift card? Okay. Dr. Rodgers, thank you so much for giving a speech about this. The past couple years, it's been me, and I'm like, I need Dr. Rodgers here to do this. So I really appreciate it. Kristen, thank you so much for attending, and thank you to everybody here for coming. It always excites me whenever I get to see all of your faces, and then I get to hear all of your questions. So I want to thank everybody.
All right.
Thank
Today,
you.
the winner is Joe Thomas. So we've got Joe Thomas here, and you won the gift card to La Madeline. So if you'll call our office, I'll put it in the chat box and I will say the phone number out loud. It is 214-987-4114. Again, that number is 214-987-4114. And I will get that to everybody in the chat box. Okay. Well, thank you everybody for attending. We'll see you next month.
Thanks, Dr. Gainey. Thanks, Dr. Rodgers.
Thank you.
Enjoyed it.
Yep.
Thank you, Dr. King. Appreciate it. Thanks, Dr. Gainey.
My pleasure.
Bye,
Thank
everyone.
you.
Y'all have a great day.